Dear ladies and gentlemen, it's a pleasure to welcome you to our European School of Urology UROwebinar Part 1 on PARP inhibitors, which will be the start of a webinar series of 3. In this series of webinars, we will tackle the role of PARP inhibitors in prostate cancer treatment. We will discuss the latest evidence and provide a practical guide in how to use them in your daily practice. So goal of the webinar series is understanding the rationale for PARP inhibitors and combinations as potential prostate cancer treatment, to get more insights on patient selection for potential treatment with PARP inhibitors, and to learn the latest developments by discussing ongoing clinical trials, also clinical trial designs, and exploring these combinations in prostate cancer. This webinar is accredited with 1 European CME credit. Upon your completion of the questionnaire after attending this webinar, you can ask questions throughout the webinar using the Q&A box you see under the screen online. And this activity is supported by an educational grant by AstraZeneca, with no involvement in the program or in the slides of the speakers. So today we kick off with the first webinar, and I am pleased to introduce Professor Dr. van der Poel, who is the head of Department of Urology at the Netherlands Cancer Institute in Amsterdam, and Professor Tombal, who's the head of surgery in the University Clinic Saint-Luc in Brussels. We will start with Professor Tombal, who will talk about PARP inhibitors, its role in treatment of cancer. Bertrand.
Thank you for the nice introduction. I'm gonna share my screen first and launch my presentation. Are you able to see it? I just have, I guess, to duplicate. So do you see it? Is it okay, everybody?
Yes.
Yeah. Do you see it well?
It's okay. We see everything well.
So thank you for the introduction. And in these next 20 minutes, I'm going to try to give you a very high overview of the role of PARP inhibition, its role on cancer, and especially in prostate cancer. So here are my conflict of interest. I've got a lot of conflict of interest, actually, but this is because probably I spent 50% of my life to do clinical cancer research in prostate cancer patients. And that's a pleasure to share some of this knowledge today. Trust me, I have absolutely no conflict of interest for the present presentation. This has not been supervised by anybody. So when you speak about PARP inhibition, it's first important to, understand where we are coming from, why is it important, why it was developed, and a very important concept, which is a concept of synthetic lethality, which is actually underlying the activity of PARP. So as you know, the genetic equipment of the cell is actually, in that system is built up a very powerful DNA repair system. Why do you need a DNA repair system? It's because in everyday life, in cancer, but just think about your epithelium when you want to have a very nice tan at the beach in Spain, is constantly exposed to external factor that actually may alterate your cell, but primarily may also alterate your DNA. And in that DNA, you may have what we're going to call injuries. That can be actually a break in the DNA. This can be single-strand break, this can be double-strand break, this can be intra-strand cross-link, but it can also be bases mismatches, a base replacing another one at the wrong place. All of this can actually lead to the cell malfunctioning, and one of the number one malfunction is actually developing cancer itself. So because of that, the cell is actually equipped with a very sophisticated system that actually can, on discovery on DNA break, repair this DNA break and restore the normal function of your DNA. One of the most common cause of break is called single strand breaks, and actually they are replaced by a very simple mechanism which is called base excision repair, BER, where a series of protein, you will recognize the name because they are actually very you hear this name very often in prostate cancer today, are implicated in these reparatory molecule. And here you will have a list, the slide will be available, of all the different reparation system, including mismatch repair, which is extremely important when it comes to the benefit of another class of agent, which is immunotherapy. So these are all the mechanism in detail, and you see that for especially the base excision repair here, you have a very important protein, which is Parp, which is actually involved in one of the first steps of the reparation mechanism. You see that in homologous recombination, you have a lot of other protein that are called DNA damage sensor protein, and a series of protein, you will recognize the name here, that are important in homologous recombination, which is actually one of the mechanisms for reparation for single strand break DNA. So all of these, we won't go in detail, just have a look on all these different mechanisms. And actually, the beauty of this is that we have realized, I mean, for many years, I mean, when I trained as a student, I actually never heard that these mechanisms were important in prostate cancer. Gene like BRCA1 or BRCA2, as you may actually realize, get their name from a breast cancer situation. So it is quite new that we have realized that they were also prominent in cancer. If you have to date back where it came clear that they had a very important role in metastatic castration-resistant prostate cancer, come probably shortly after 2010, where famous study like the Robinson study, which is basically an autopsy study, started to realize that beside the AR pathway, which was the natural conception, actually metastatic castration resistant implies that it's a resistance to hormone therapy and thus to androgen receptor in general. But it became clear that beside this pathway, there were also very important pathways, including cell cycle, genes such as retinoblastoma, PI3 kinase pathway with very prominent mutations such as PTEN loss, AKT, which is very important because it opened also possibility for drug inhibition, the WNT pathway, and came probably as a surprise for many of the scientists, although people in the field know that for a few years, the fact that DNA repair alteration were actually very commonly found in these patients with prostate cancer. And you see here, DNA repair, you see that many of these patients, yes, for sure, the number one is still AR, P53 and P10, but you see that many patients were actually identified with DNA repair alteration. And that came with this idea of a list of usual suspects. And in these usual suspects, together with the androgen receptor P53, P10, and other AR-regulated gene, you could find actually genes such as BRCA2 and ATM, which are still today the most frequent alteration in DNA repair, and that Hank will go in detail with you when it comes to that. So that was the first observation that clearly in metastatic castration-resistant prostate cancer, on autopsy, it was found that many of the metastases would have this mutation, and then very rapidly had a wealth of paper like that very important paper by Pritchard, showing that actually DNA repair alteration can be found, let's say, somewhere between 10 and 20% of men with metastatic cancer. So really, that was quite an eye-opening discovery. Based on them, based on this came also to the consideration that this was not common to prostate cancer. This is actually one of the key features of ovarian cancer and to some extent breast cancer. And at this point in time, already a few years ago, some researchers had discovered for that situation the so-called context of synthetic lethality. So what does it mean? It means that actually if you look at DNA damage, and if you look at normal cells, in normal cell, like I showed you before, there are multiple redundant pathways, meaning that cells may actually always promote cell survival and repair alteration because there are many pathways. And if one of these pathways is mutated, the cell may still rely on alternate pathway to promote its cell survival. And this is something that you're going to find in cancer cell. And very interesting, if actually you can introduce in the cell a specific inhibitor of one of the pathway, that will result in normal cell into limited activity because they are still on the pathway. But in the cancer cell that are actually missing one of the pathway, that can actually lead to synthetically causing lethal damage to that cell, and actually without any reparation of the DNA lead to cell death. So that concept is important. This is around that concept that in 2005 you can date back actually the first attempt to use DNA repair defect as a therapeutic strategy in BRCA mutant cells. And that's actually, these two papers are the first to really mention in Nature 2005 to mention using inhibitor of the poly-ADP ribose polymerase, which is the name for the PARP, as a way to specifically kill BRCA deficient cancer with BRCA deficient system. So, and that actually all these PARP are working. So in a normal system, when you've got like strand break DNA, you can see that actually these, as mentioned previously, will be replaced by base excision repair. But if in this system now you are actually blocking the important PARP enzyme, mostly by mechanism of trapping the PARP and blocking the release from the DNA, actually, if you do that in a normal cell, that may actually lead to replication and cell survival. But in a patient who has a BRCA mutated system or a poorly functioning BRCA system, that will lead to cell death. So that is basically how these PARP inhibitors are working, by hijacking a reparation system, which and then actually putting the cell in a situation that because the mutation, she cannot survive anymore. So the first observation came actually from Johan de Bono's group, which has done most of the work on the topic. Johan has always been one of the, probably one of the most visionary researcher in prostate cancer, and they came with that publication in New England 2005, showing that actually if you treat metastatic CRPC patient with olaparib, if the patient were biomarker positive, meaning that they had alteration in BRCA2, mostly actually you had a nice survival, where patient with biomarker negative had actually a very short overall survival. So that has basically opened the field for introducing PARP inhibitor in prostate cancer. So actually the first development was to say, okay, let's use that knowledge from the Robinson paper. We know that patients who have metastatic CRPC are actually developing DNA repair mutation. So let's use these PARP inhibitor in patients who are progressing on AR-targeted agents such as abiraterone or enzalutamide, who may have received or not docetaxel, but that harbor DNA mutation. So we are actually in the disease pathway somewhere here. You know that today many of the patients at the metastatic setting will receive ARPi, ARPA, ENZA. We should add DARO, that we treat non-metastatic CRPC patient with ARPA, DARO, ENZA, that then if they've not been treated yet, they could only receive ARPi or ENZA at that point. But then these patients at some point progress, causing a situation I personally call the conundrum of the third line. So basically, 4 agents have been tested in that setting. Several are now approved by FDA and 2 by EMA. Only one has actually been developed on a proper phase 3 trial. The other one have been approved on phase 2 trial. That's why here I'm going to give you kind of a big overview of the 4 agents, but then we're going to go in detail of the phase 3 trial, because this is really where you've got most of the message from these agents. So all these trials were actually designed in patients having received 1 ARPi plus docetaxel, or eventually optional in the PROFOUND trial. You see here the approval status. Interestingly, in Europe, EMA has approved only in patients harboring BRCA1 and 2 mutation, where the FDA has approved based on the broad concept of DNA repair mutation. The phase 2 trial were based on objective response rate and PSA response. The phase 3 was primarily designed to measure radiographic progression. In patients with alteration in ATM, BRCA1, BRCA2, there is a second part of the trial I'm going to show you. All the specimens tested include tumor tissue, plasma, so various kind of tissue. Most of them use Foundation 1 test. The resolution test was used for the niraparib. And here, you're going to see that in the detail if you want to see further all the genes that were included in the panel. And they all actually accepted patients with mono on biallelic DDR alteration. So the first observation actually, and this is a phase 2 trial, is that it's a precision medicine treatment. So meaning that if you restrict the usage to patients with BRCA1, BRCA2, you may have to screen a lot of patients to find the happy few. So that's a problem. Urologists should know, and I'm sure that Hank will discuss that in detail, that despite the enthusiasm we have now toward this drug, we must admit that we have many more patients to which we say we're not going to give it to you. That patient, we say, oh, you're a good candidate, we're going to treat you. So that's something, that's some form of important frustration we may to discuss later on. So you see that the objective response rate for BRCA1 is always excellent. Once you go outside BRCA1, you see that the response rate is much lower. When it comes from the toxicity, you've got the quadruple toxicity, mostly anemia, thrombocytopenia, some fatigue, and some nausea. So these are oral agents, very easy to administer. However, we need to notice that 1 patient out of 10, a little bit more than 1 patient out of 10 may discontinue the drug for the adverse event. And dose reduction may happen very often, and sometimes close or even more than 50%. So that's very important that when you give this drug, you do anything to properly monitor the patient. That will be discussed later on. So let's come to olaparib. Olaparib was the only one to be tested in a large phase 3 trial until very recently. 2 cohorts. Cohort A, patient with DNA mutation BRCA1, BRCA2 ATM, cohort B, other alteration. As mentioned, olaparib 300 BID versus physician choice, which most of the case was another AR pathway inhibitor. rPFS in cohort A as the first endpoint. And needless to say, the hazard ratio is quite impressive, 0.34, which is actually similar hazard ratio that you could find with ARPA, ENZA, or ARPi in first line, with an extension of PFS from T.6 to 7.4. So that's basically doubling the PFS in a group of patients that have been severely pre-treated. Although this was not the primary endpoint, the overall survival were expected very eagerly and were reported by Maha Hussain in the New England Journal of Medicine in 2020. And you see that you have a major benefit in overall survival with a reduction of 30% for the cohort A, meaning BRCA1, BRCA2, ATM. It's unfortunately not the same for the cohort B. So that actually study included a lot of crossover, so it was normal to actually adjust for overall survival for crossover, and when you adjust overall survival for crossover, you've got a reduction of around 60%, so very major effect both on PFS. Very recently published, it's still online. Quality of life, if you look at pain interference, for instance, which is a very important quality of life measure, because this is not only pain, but the impact of pain, how it interferes with everyday patient life, you see that actually the benefit is important. Toxicity, not very different from the two other agents, mostly anemia, nausea, fatigue. And you see that, once again, discontinuation due to AE, 16%. So we may have to work a lot to properly educate people who are giving these drugs, because that's not sugar pill. You're going to have to learn to manage this side effect. Otherwise, the patient may stop the treatment, and that's not a good idea. So that's the beginning. It's already available in many European countries. So I think that the implication will be discussed by Ang, but that is very important to understand. Now, we should know that not all DDR mutations are equals. Dr. Van der Poel will come in the detail of this. But as mentioned in prostate cancer, the most frequent are BRCA2 and ATM, also CDK12 to some extent. When you look at the efficacy, it is more or less, we may say, restricted to BRCA1, BRCA2. We don't know yet exactly what is the activity on each of these individual DNA repair mutations, so that's going to need much more work before we can clarify this. This has been reported, and you see it, so major. You understand that based on this, decision was taken by the European, by the EMA to grant for BRCA1 and BRCA2 only, so very important, although BRCA1 should be considered a rare event in prostate cancer. So beside that, you can go into the detail of the germline. Is it a germline mutation? Is it a somatic homozygous deletion? It is a somatic mutation. Is it a biallelic hit? Is it a monoallelic hit? I think that for the response, you see it will vary. So the difference between germline and somatic, that's not too much to be discussed. But clearly, you see that for BRCA, it may vary by the exact time of mutation, and this will be actually clarified in the future. And so far, this has been observed also for Riracarib and Olaparib. So once again, BRCA, mostly ATM, not a good idea. CDK12, not a good idea, probably a target for immunotherapy. For the other, we still need a lot. So more interesting to finish that presentation is the two posters that were actually presented, two oral presentations that were presented at ASCO, namely Propel and Magnitude. Why? Because actually the idea is, we know that enzalutamide and abiraterone are actually having an effect on DNA repair mutation. The number of patients with DNA repair mutation is increased. We know also that PARP inhibitor may actually increase the efficacy of especially abiraterone. This has been shown in a very nice paper by Karen Knudsen. So why not to combine upfront the PARP inhibitor with abiraterone in the first-line metastatic setting, when you know that both probably will be interfering? And so this is a very important observation made by Karen Knudsen group, that PARP inhibitor increase efficacy of ARPA2 inhibitor, and ARPA2 inhibitor induce HRR deficiency and increase susceptibility for PARP inhibition. So based on this, I will show you two trials. The first one is the Propel trial. First author is Fred Sad. It's a phase 3 of Olaparib plus abiraterone in patients with first-line metastatic CRPC. We may discuss whether this patient still exists or not. And this primary endpoint is radiographic progression of death. Very interesting trial. Very important benefit in terms of rPFS in favor of olaparib plus abiraterone with a hazard ratio of 0.61. And you see the increase at 12 and 24 months. And interestingly and surprisingly, a benefit which is seen also in patients without detectable DNA repair mutation. So that's the first time in prostate cancer. It's been shown in ovarian cancer with niraparib that it's not only limited to DNA repair mutated patient, but also based on the data, there is an efficacy in patient without DNA repair mutation. So very, very provocative result. So toxicity actually very similar to what is seen with olaparib after abiraterone. So no major increase in toxicity, same rate of discontinuation, very few discontinuation of abiraterone, so no surprise regarding the toxicity. So that's something very important. And then people will say, but you know, why would it be like this? I think that probably two explanations. The first one is that you test the patient before you start the combination, and as shown, the combination may have some efficacy. And also, if you are interested in the topic, there are a lot of publication on actually the non-DNA repair pathway leaded activity of PARP inhibitors. So the observation made by Fred Saad not only is supported by data, but it's also plausible. And as mentioned, it's been shown in an adjuvant trial with niraparib in ovarian cancer. Beside that, there is also the magnitude trial, similar trial with niraparib, first author Kim Chi, same design, 2 cohort, HRRBM plus HRRBM1. And then, surprisingly, in contrast to what is seen in Propel, there was no efficacy of niraparib at the interim analysis, so that the study was stopped. So what we can say as for today is that niraparib failed to show a benefit in combination with abiraterone in patient first-line metastatic CRPC. So this is a major difference between magnitude and Propel that's going to have to be discussed. These results are still fresh, so as you may guess, there's still a lot of ongoing discussion. In patient with BRCA1, BRCA2 mutated, very nice benefit in rPFS, very similar to olaparib, hazard ratio 0.53. If you take all DDR, it's 0.73, but once again, pointing at a very nice benefit in patient with BRCA1, BRCA2. Toxicity, a little bit more toxicity, but the study may be a little bit different. So there are a lot of questions around this. Number one toxicity, once again, was anemia and thrombocytopenia, but all over the combination is feasible. And I think that together, these two trials will really be practice changing. So once again, here, BRCA with other, so an effect that is mostly restricted to BRCA1, BRCA2 patients. So in conclusion, I think that this PARP inhibitor study as the first biomarker-driven phase 2 and 3 trial in prostate cancer, they really established PARP inhibitor as standard of care in men progressing and or receiving, that's very important, an AR pathway inhibitor in the metastatic setting. There's still a lot, however, toxicity is manageable but significant, leading to common dose reduction. Screening is still tedious. Major education needs to be done, and you're going to do that with Dr. Vanderpoel. At this time, benefit is most limited to variant with BRCA1, BRCA2 mutation. But Propel clearly suggests a potential benefit beyond BRCA1, BRCA2. More study will be needed to assess response in patients with less prevalent alteration. And also, I've not discussed that for sake of time, previous therapy, especially previous docetaxel, and I think that I will see with that with you, may also affect response to PARP inhibitor. Thank you very much for your attention.
Thank you very much, Bertrand. This was a very nice talk. We will have the Q&A together after both talks. So I would invite Henk to give his lecture on integrating PARP inhibitors into advanced prostate cancer therapeutics. Thank you.
Thank you, Daria, and thank you, Bertrand, for this nice, so to say, introduction on the basics of PARP. I always find it very complicated being a practicing urologist to understand the genetics on it, but I try to continue a little bit with a more clinical and practical input, and there may be some repetition in this presentation, which I think is crucial for you to understand. So basically what we do now for prostate cancer is that there is an increase in genetic alterations going from local regional disease up to castration-resistant disease. And another thing that's very important is that there is a variation among patients with castration resistance to the extent of genetic alterations that are present. So the focus of today is basically look at the data from the PROfound study. It was already highlighted by Bertrand, looking at the homologous recombination repair gene alterations in castration-resistant prostate cancer, which is the target of the PARP inhibition, and shown earlier that BRCA2 is the most important and most prevalent gene mutated, and being an interesting target for treatment. So briefly, I show you the slides that I want to discuss the next topics on. I'm going to talk a little bit on the timing of genetic testing. I'm going to talk about the difference between somatic and germline testing. I think it's important for a practicing urologist to understand that. To have a look at, should we test a primary tumor or should we test a metastasis if we think patients are eligible for PARP inhibition, and which genes actually do we need to test in order to find that out? Is there toxicity? Are there some contraindications for PARP inhibitors? What about combination therapy? We saw the very interesting data from the Poel study. And what can we do with maintenance PARP? Other cancer treatments are using maintenance PARP already, and in prostate cancer it may be the next step. So first, I want to highlight a little bit on heredity. We know BRCA is associated with an increased risk of breast cancer, but recently it's also shown that it is associated with an increased risk of prostate cancer. So when to test for hereditary diseases in patients with prostate cancer? What was interesting that a recent survey among medical oncologists and urologists in different countries showed that the majority of medical doctors actually have some very clear indications to go for genetic germline testing. And if you talk prostate cancer, then you should think about germline testing and BRCA in particular. If a patient has a family history of high-risk prostate cancer, breast, ovarian, pancreas cancer, and has cancer at a younger age, which is a particularly increased incidence in patients with BRCA mutations in their germline. Also, a Jewish descent is a risk factor for that. So briefly, and this is not the topic of today, but I want to show you, because BRCA is more than only castration-resistant prostate cancer. The hereditary factors in prostate cancer are thought to be up to 50%, and BRCA1 and 2 mutations have an increased risk of prostate cancer in family members. For that, BRCA2 is the most prevalent in patients with prostate cancer, and in particular, BRCA2 mutations in your germline increases the risk of developing prostate cancer at younger age, higher Gleason score, and also intraductal cancer with a higher risk of progression. So looking to somatic and germline mutations, somatic being in the cancer cell and germline being in the germline cell, you see that the somatic mutations in the BRCA line are still higher compared to germline mutations, but germline mutations can be found in up to 30% of patients with a family history of prostate cancer. I think it's important to remember that and use your medical and family history to decide on further treatment and testing. So if a homologous recombination repair gene problem is detected, what next? What does it mean for the patient? Well, first, I think it's important, we've seen all the agents now, the PARP inhibitors, and there are basically 6 or 7 of them, of which 5 mentioned here in blue are used in prostate cancer management. And actually, the thinking is, and one of the questions came up in the Q&A already, is there a difference between the agents? And the Prof and magnitude study data seem to suggest that there may be, but I think it's a population difference that makes the outcome difference among the studies. So the thought is now that there is equivalent activity of the different PARP inhibitors available. The basics of synthetic lethality have been discussed, I think, very nicely by Bertrand. So briefly looking at the studies and then focusing a little bit on the populations. These are the major studies now published on olaparib, and basically that's the best studied agent PARP inhibitor at the moment. Most of the patients, or all of the patients, had metastasized castration-resistant prostate cancer, and in most studies, many of the patients had earlier chemotherapy. And the endpoints, the primary endpoints of the study, were not overall survival so far, so we have to be careful on any conclusions. But the other agents that were studied in prostate cancer and brief summary of the studies published now also show that many of these studies used pre-chemotherapy treated patients and had an overall response rate as their primary endpoint, but the responses in BRCA1 and 2 mutated patients was impressive with 40 to 50%. So what about subgroups of patients that may particularly benefit of olaparib inhibition? And these are data from the follow-up of the PROfound study with respect to overall survival, showing that indeed patients with no prior chemotherapy, at least in this study, in the PROfound study, may not have a clear benefit of olaparib treatment. That's what was suggested by the PROfound data. Interesting also here, and this may not hold up true for newer study populations, but at least in the PROfound was shown that patients with only visceral metastasis seem to have less benefit from olaparib. So what happened to olaparib? It was FDA approved in the United States in May 2020 for BRCA1, BRCA2, and ATM mutations, and also for the group B in the PROfound study with more extensive panels of HRR mutated genes. So which patients to select? Well, basically it's clear that from the study data, patients with metastasized castration-resistant prostate cancer are the main target. I still have a question on whether visceral metastasized patients only should be included, but earlier taxane, Abi, or enzalutamide treatment is not a contraindication, and these patients may all benefit. There may be differences among PARP inhibitors with respect to the response in prostate cancer. We still wait for data, but there are no comparative studies comparing the different inhibitors in prostate cancer patients. So if you look to the recommendations of ESMO, they devised the scale, the SCOT scale, in which the level of evidence for using genetic tests in patients with cancer is summarized. And BRCA1 is on the top of the list, being the routine target for genetic testing, whereas the other HRR mutated genes, ATM and POB2, are more evident. They are still investigational. So what can be done about the critics? What can be said on the critics of PROfound? And I think there is a nice editorial written by Kwon last year in European Urology, stating that in his view, there are 4 major problems with the PROfound study that need to be addressed in further studies. The first thing is that the comparator group, the control group in the PROfound, was treated with ARTA. And this, after earlier ARTA treatment, is not the recommended policy at the moment. Then again, there was crossover of the control arm that may have delayed chemotherapy. And there was some discussion on the use of radiographic progression-free survival. Though with the data from Hussein published later in 2020, there was also a benefit for overall survival. So I'm not sure if that critic really holds up at the moment. So the main question is, if you have a patient with prostate cancer, what is the exact moment that you should go for gene testing? There's discussion on 2 options. You can either select to go for very early. That means at an early advanced prostate cancer stage, even when there are no metastases and the patient is still hormone sensitive. The benefit of doing that is that you have an increased risk of BRCA1 and 2 mutations, and this may be in germline as well, and that may have consequences for a patient's family. The other argument is doing it early, is that the patient is still in a good condition and can still receive many of the treatments available for patients with metastasized prostate cancer, and early testing can help you to sequence and to schedule different therapies. If you do early testing, the suggestion is to take a large panel because future therapies may be available very soon that will have impact on the gene panel that you study. Sequence treatment, was said already, can be done if you know the genetic alterations in a very early phase, and tumor material, in particular in patients after prostatectomy or lymph node dissection, may be more readily available than in patients with minimal metastasized castration-resistant prostate cancer. So there are also some contrasts of testing early. It may not have direct impact on treatment of the patient. There may be mutation accumulations over time in disease progression, and there may be in development new targets that you need to test later on. And as well as progression, there will be new metastases that can accumulate new mutations. And don't forget costs for genetic testing, which is about now $7,000 at the moment. So what's the recommendations on testing? And I just selected two larger guidelines, the NCCN. The NCCN is very open and says you have to do it as quick as possible. Like I said, you can do it in patients with metastasized hormone-responsive prostate cancer, especially if you go to HRR genes. The EAU guidelines are a little bit more restrictive, and they recommend testing of HRR mutations and MMR mismatch repair defects genes in metastasized disease, so not only in castration-resistant disease. And if you do so, what do you find? Well, these are interesting data from a couple of years ago showing that in patients with metastasized castration-resistant prostate cancer, the frequency of genetic alterations is the highest for the whole progress of prostate cancer. And in particular, AR and P53 accumulate in patients with metastasized castration-resistant prostate cancer. So if you look in particular to BRCA2, it's very interesting that there is no significant difference in the frequency of mutations in patients with either local regional disease, hormone-sensitive disease, or castration-resistant disease. So for BRCA2, you may actually go and get information on PARP sensitivity in a very early phase of disease. So if we don't know, we sit together in a consensus here, which is the APCC just recently published, and they ask the same thing, is when do we have to do genomic profiling? And it should be performed in patients with advanced prostate cancer, as the NCCN recommends. But there is no standard to when this actually should be done at the moment. Then the next question is, if you consider patients for PARP inhibition and you want to do genetic testing, what is the material that you need for testing? Well, the most important thing is that prostate cancer and every cancer will progress over time. And the question is, do I take the primary tumor as my source of material? Do I take the primary metastasis? Do I need to take multiple metastases to get the answer on the specific targets you need? Well, again, going back to the recommendations, the NCCN states, similar actually to the EAU, that there is a preference to select metastasis for genetic tests. Interesting, and the data were already shown, is that the ctDNA, so the circulating tumor cell DNA and the circulating tumor-free cell DNA, is now available and a commercial test, as is the Foundation 1 is now FDA approved, as is recommended and it's stated in the EAU guidelines. So continuing and summarizing a little bit on what ctDNA is, it's a blood test that can easily be done and was shown to show strong correlation with mutations as compared to tissue material from solid tumors. The test itself is now available. As that, it's the Foundation 1 CDX test. There are three different problems. There are three different options doing the test. It can even, if there is sufficient tumor DNA presence in the blood sample, be done a comprehensive coverage test, including 324 genes. If the amount of DNA is limited, there will be tested only 75 genes. And if it is not sufficient for any testing at all, it is always recommended to do a reflex test on metastasis material. So the interesting question is certainly, is there a correlation between the mutations found in the circulating tumor DNA with respect to the primary tumor as well as to metastasis. And this was an interesting study in 51 patients finally evaluable, in which there was a comparison made. And indeed, the number of mutations and the genetic alterations between the primary tumor and the circulating tumor cell DNA was quite high with 92%. And there was no significant difference between either the presence of mutations in the metastasis compared to the primary as compared to the ctDNA. So it seems that ctDNA is a very good valid surrogate for what's going on in the metastasis. Then again, if you do the test, which genes need to be tested in order to make patients eligible for PARP inhibition? Well, the interesting thing is, and data were shown, and these are earlier data from the PARPi study, showing that basically patients with BRCA1 and 2 have a better progression-free survival benefit from olaparib when compared to the other mutated genes in the HRR family. Even if you compare BRCA1 versus BRCA2 mutations, both FDA approved for PARP inhibition, there seems to be a slight advantage of patients with BRCA2 mutations with respect to the response to PARP inhibition. And that's also found here in the PROfound data. These are the overall survival comparison. Patients with ATM, and I think Bertrand, this is a repetition maybe, but Bertrand showed it as well. ATM patients may not benefit as well as do BRCA2 and BRCA1 patients, but there is a larger error of difference. And the interesting population is the PPP2R2A patients that may even do worse with PARP inhibition. Interesting to know that. So then again, what if a somatic mutation is found either in the blood or in the tumor of the patient? What should we do? And the patient asks, does it have impact for my family? So do I need to do genetic testing as well? It may not affect treatment for himself, but it may be of consequence to his family members. And the interesting finding is that if you do find a somatic mutation, BRCA, in the tumor in patients with metastasized prostate cancer, there is an up to 42% chance that you have a germline mutation. If you go even earlier in patients with non-metastasized disease, then there is a 60% chance that you find a germline mutation, and this will have consequences for the patient. The question is, does it matter for the patient if the BRCA1 or 2 mutation is found in the germline or in the somatic samples of the tumor? Well, basically, there is data on that of other tumors extensively, and I summarized and showed the data of a summary here of 2 years ago, showing that patients with ovarian, pancreatic, and prostate cancer summarized there is no significant difference in the response to PARP inhibition, having either a somatic or a germline mutation. So I think briefly, before we can go to the questions, I think it's interesting to have a look at the toxicity. And I already repeat here what was already said by Bertrand, I think. Anemia, nausea, and fatigue are very frequent in patients with PARP inhibition and sometimes require dose reductions. Other complications were not significantly different with the control group in the PROfound study as presented in this table. So the interesting question is, if you change the DNA repair mechanisms in cells, you may do that as well in non-malignant cells, so in non-target cells. And this may be mutagenic over longer periods of time. And it is interesting to show here some xenograft data that show if you give mice in xenograft models longer periods of PARP inhibition, that there is not a sign that this may lead to a mutagenic effect, which can later cause cancer. So longer periods of time certainly are needed to exclude the mutagenic effect of PARP inhibition, but preclinical data suggests that the drug is safe with respect to that. So what are rare and potentially very lethal side effects? Thromboembolic events occur in 7% of patients, so it needs to be addressed there. The myelodysplastic syndrome was shown to be 7%, but in the data from olaparib now published so far, the data is much lower, and pneumonitis can occur in 7% of cases. So you need to know how to manage these toxicities in order to prescribe the PARP inhibition. Is there a big difference between the toxicity of the different PARP inhibitions? And these are data comparing grade 3 and 4 toxicity of olaparib, niraparib, and rucaparib. And there basically is some detailed difference in toxicity, but the overall differences seem to be limited. What is the major contraindication for PARP inhibition? And both renal and liver insufficiency are a reason not to prescribe PARP inhibition, in particular if the eGFR is less than 30. In other cases, there is an option for olaparib to do a dose reduction to 2 times 200 milligrams daily. Was already mentioned in the earlier table. I think it's interesting to know that not all HRR mutations are more amenable to PARP inhibition, and in particular the PPP2R2A patients should be excluded from PARP inhibition. So the question is PARP inhibition a very expensive way of treating patients with prostate cancer? Well, the daily dose in the United States is about $250. In my country, that sums to about 8,700 euros on a monthly basis. And in an ICER evaluation published last year was shown that the ICER, the incremental cost efficiency ratio for the treatment of PARP with PARP inhibitions or olaparib was about $116,000 per QALY, which is below the $150,000 dollar per QALY that was the willingness to pay at the current moment. So it seems to be cost effective to use PARP inhibitions in patients with metastasized castration-resistant prostate cancer. So is PARP inhibition the final step in the treatment of patients with metastasized prostate cancer? And it seems not to be the case. Is there anything else? Is there maybe a combination possible? And thanks to the nice slides from Bertrand, I think we already know a lot about PARP inhibition and the effects on the genetics. And this is a slide summarizing the resistance pathways to PARP inhibition. For sake of time, I continue, and you recognize the next slide. The next slide is again data from Robinson showing that there is more on genetics in patients with metastasized prostate cancer than PARP inhibition. So the interesting question is, can we combine? And we already seen that the Propel and Magnitude data combine AR inhibition as well as DNA repair PARP inhibition. But what about other pathways that may be combined with PARP inhibition in order to increase the efficacy? And one of these pathways is the PTEN-AK2 pathway, because it's very interesting that is shown here that the amount of mutations and in particular DNA losses of PTEN expression surmounts in patients with metastasized prostate cancer. And these are early data from preclinical studies showing that combining AKT inhibition with PARP inhibition increases cell toxicity in cell lines. And this was also leading to a clinical ongoing study using a AKT inhibitor with rucaparib. So finally, I want to make one sidestep from PARP inhibition to another target of BRCA BRCA2 1 or 2 mutations, which is the treatment of cisplatin. Cisplatin is now growing a little bit in the treatment of patients with metastasized castration-resistant prostate cancer. And the interesting observation was done some years ago that indeed patients with BRCA 1 and 2 mutations may be more amenable to cisplatin therapy, as is shown here in the overall survival curves in patients without and with a BRCA mutation and response to cisplatin. So maybe cisplatin treatment may be a nice follow after PARP inhibition. So we've seen the data now of Propel and Magnitude, and I hope we have some minutes for discussion, Daria, if we finish there. But because I'm really curious what Bertrand and the audience thinks on the different findings from these two studies, certainly. So what's ongoing in combination therapy? I think Bertrand mentioned it. Enzalutamide instead of abiraterone may be combined with olaparib in the TALAPRO-2 study, and certainly also in patients with microsatellite instability, pembrolizumab as an immunotherapeutic agent and olaparib in the KEYLINK 010 study is very interesting, and we're looking forward to the data. So I mentioned, what about maintenance therapy of PARP inhibition? And basically, most of the studies so far are done in non-prostate cancer, breast cancer, pancreatic, and ovarian cancer. Basically, the summary is that all these studies show that BRCA after chemotherapy may prolong survival and give a disease-free survival advantage of roughly 10% in most of the cases. And two clinical studies are ongoing in the field of prostate cancer, as is mentioned on this slide. So even further in the future, I think, and this is interesting data, very provocative data showing that BRCA agents can be combined with either HDAC inhibition or, as mentioned, PI3 kinase AKT inhibition as a single agent, and with that respect, maybe even more efficient. I'm not sure if there are any clinical trials ongoing, but this is where some of the lines may be leading us. So this brings me to my final slide, the conclusions. I think for us urologists, it's very exciting to see that genes are very hot in prostate cancer finally. Working in the field for almost 25 years and looking at a lot of genes, I think it's very interesting to see that these genes finally make it into clinical practice, and they do so for patients with metastasized castration-resistant prostate cancer in the PARP inhibition era, but also for patients with a family history of genes associated with these mutations. So BRCA1 and 2, I think, are the novel targets and most interesting in the field. I think overall survival improvements up to hazard ratios 0.42 are being achieved in the most clinical studies. And in particular, after taxane chemotherapy, PARP1 inhibition, I think, is a very interesting and appealing option. Mutation analysis is very helpful, and ctDNA in the blood will, in my view, be one of the key factors of using because it's so simple and easy to apply. PARP inhibition seems to be cost-effective in the management of patients with prostate cancer metastasized disease, which is often a very expensive period of treatment, and the toxicity seems manageable. And for me, I think the future lays in the combination of PARP inhibitions with other agents available. And I want to stop my presentation here and give the microphone back to the chair, Daria.
Yeah, thank you very much. We learned a lot today about PARP inhibition. Unfortunately, we don't have that much time now for discussion, but we had some chats already ongoing in the Q&A with most of the questions answered. I want to ask one question because this was also asked in the chat, and since ASCO GU 2022 just was finished last week, I would like to hear Bertrand's view on the differences we saw in magnitude and Propel. While in Propel, the benefit of adding a PARP inhibitor to abiraterone led to a benefit in rPFS independent of HRR mutation status. We did not see this in the magnitude study where biomarker negative patients did not profit from the combination where niraparib plus abi was used. Bertrand, you mentioned that obviously the discussion is ongoing because these data are very fresh, but what are your thoughts?
I think, as you may guess, there was a lot of ad board going in, trying to say why it was like that. So first of all, this is plausible that there is an activity outside BRCA1, BRCA2. Keep in mind that actually the screening was done before the combination was started. So meaning it is possible that actually the combination behave like it was predicted in that very nice paper by Karen Knudsen. So then why olaparib and not niraparib? Nobody knows, especially that in ovarian cancer, niraparib had shown exactly the opposite, that they had an action. So there were a lot of discussion where people mentioning that maybe the the test they use to detect DNA repair mutation actually misses some patient, but that was clearly refuted by Fred Saad. Then there was a kind of worry about an increase in toxicity of niraparib that could have actually decreased the dose administered to the patient, but Kimchi provided reassuring information on the fact that the dose was actually corrected in most patients. So I think that first, we're going to need to have the final publication to really dissect the patient to understand the line of treatment. There is also, so we should see at how many patients have received docetaxel before in the hormone-naive setting, because as shown by Anke, there are data showing that it may work better before docetaxel and after docetaxel. So at this point in time, the problem is that usually you've got one a little bit better and the other one a little bit negative. But here the problem is that the fertility analysis is really negative, and the Propel data are really positive. So once again, it reminds me when we had only Charted and GTUC15 for docetaxel. Charted was negative, GTUC15 was Charted was positive, GTUC15 was negative, and it needed a third trial to clarify the situation. I think that everything is going to be clearer when we're going to get a result of trial like TALAPRO. In the meantime, I think that the question will go to a reimbursement authority to see whether they will allow that extension. But so at this point in time, I have no definitive answer. What is clear is that we should check for DNA repair mutation much earlier. But I think that the early combination with BRCA1, BRCA2 before they progress on ABI is clearly the most important information from these two papers.
Thank you very much. So unfortunately, we have run out of time, but I'm seeing that in the Q&A, all questions will be answered. Actually, there are no open questions. I would like to thank Professor Tombal and Professor Vanderpoel for their nice talks, and I hope to welcome you for parts 2 and 3 of this webinar series. Thank you very much.